And good morning and welcome to this session. It's a pleasure to have everybody here. And today this session is entitled Enhancing Multidisciplinary Care Through Cognitive Testing. My name is Jed Grisel. I'm an otolaryngologist. My practice is in Wichita Falls, Texas, which is about 2 hours from Dallas. My practice is a private practice that is a comprehensive ENT practice. So 5 physicians, 4 audiologists, 2 nurse practitioners. We do allergy and hearing aids. So a very typical comprehensive ENT practice. And it's a pleasure to be able to be sharing this topic with you today. By way of disclosures, and in transparency, I am a consultant for Cochlear America as a cochlear implant device manufacturer. And I'm also a consultant for Cognivue Inc., which is an automated technology for assessing cognitive function. So today we're going to talk about 3 main topics. The first is that we're going to try to understand a little bit between the association between hearing loss and cognitive function. This may be something that people are aware of, but just to bring us all to sort of the same level from a research and literature standpoint, we're going to discuss that. Secondly, we're going to talk a little bit about how cognitive function is assessed in general. And then we're going to compare paper and pencil methods to automated methods and some of the differences between those two. And then finally, we're going to end by discussing, as a busy clinician, how we can incorporate cognitive testing into our practice in a way that improves the experience and value for our patients. So those are kind of the 3 main topics. And so we'll just go ahead and just get started with the first topic of understanding hearing loss and cognition. Okay, so one of the reasons why I'm passionate and very interested about hearing loss is because of the association that hearing loss has with many other health issues. And so we know as clinicians, and we've been talking about this with our patients for years, that untreated or late treated hearing loss increases our risk for many other types of negative health consequences, such as significantly increased risk of developing dementia, higher risk of depression, increased risk of falls, more hospital stays, and the list goes on and on. And Johns Hopkins about 2 years ago published a study where they evaluated claims data over 10 years to see how patients who have untreated hearing loss compare to their normal hearing peers in terms of overall healthcare spending. And what they found is that if we have untreated hearing loss, then that is associated with about 46% higher overall healthcare spending compared to their normal hearing peers. And so we know as clinicians that hearing loss has profound impact in the lives of our patients. And so digging a little deeper into the specific relationship between hearing loss and cognition, over the years, the interest in research has sort of coalesced around understanding what are the etiologies for how that link is related. Okay, so this is some summary from Frank Lynn's research about 6 years ago that describes this relationship in 3 proposed etiologies. Okay, so the first of these is called cognitive load. And the idea about cognitive load is the concept that our brain only has so much cognitive resources at any given time. We can only perform so many cognitive activities at any given time. And so when we have hearing loss, that degraded sound signal requires more cognitive resources to process than a normal sound signal. And so those extra resources have to come from somewhere. And that somewhere tends to be things like working memory and executive function and other cognitive skills. So that's cognitive load. The second etiology that relates these two is that when we don't stimulate the auditory pathway, we know from volumetric imaging studies that those areas that manage sound signals actually decrease in size. So decreased stimulation of the auditory pathway actually changes brain structure and function. And then the third, we know that patients with untreated hearing loss engage less in their environment. Family gatherings, church outings, restaurants, those sorts of things. And that decreased social engagement has profound implication in terms of cognitive function. We also, of course, have to recognize that there could be common etiologies. So a common neurodegenerative process that affects both the auditory pathway and cognition. But at the end of the day, what we know and what is becoming increasingly clear is that not only is good hearing required for good cognition, but also good cognition is required for good hearing. And the reason behind that is that we live in a very complex world, a noisy, very competitive world when it comes to sounds. And there's this concept called bottom-up processing, where the sound signal comes from the environment through the ear up the auditory pathway to the brain, and that's bottom-up processing. But that's not enough for us to be able to efficiently engage in speech and language. And so we also have this idea called top-down processing, where our working memory, contextual clues, those sorts of things are used to supplement that bottom-up processing and combine together to provide a good experience for us in our environment. And cognition plays a very important part in that role. Okay, so hearing and brain function are intimately related, and they will never be separate. Okay, so this slide here summarizes the findings of a study that is sort of a landmark article now. Most of us are aware of this, but I think we can't have this discussion without showing this study. This study was done in 2017, and then it was updated in 2020, and it was published in the journal Lancet. And the way to look at the findings of this study, is that this image that you see on the left-hand side of the screen is something called a life course model for dementia prevention. And what that means is that when we think about dementia prevention, we have to think about this in terms of what are the modifiable risk factors that you and I as clinicians can work with our patients to actually change the trajectory or change the course of dementia. And some of these modifiable risk factors we can engage in early life, some in midlife, and some in late life. And so the way to read this is that very thick gray bar represents the proportion of dementia that is not preventable. So about 60%, that you and I can't do anything about it. It's in our genes. It's going to happen. The other items that you see here are risk factors or life modifiable behaviors that can actually affect that outcome. And so we see from this that of all of the different things at any given time in life, intervening in hearing loss during midlife is the modifiable risk factor with the strongest link to dementia. Okay, so basically, there's a growing body of research that's supporting these findings, and it's talking about that we can potentially alter this course of dementia by intervening in hearing loss in early or midlife, I should say. And so this is an example of one of these studies, another example of one of these studies. This was performed in the United Kingdom, and basically what this study found was that if patients engaged in hearing aid use, for some of these patients, their memory scores, the natural expected decline in their memory scores was lessened by using hearing aids. This was not a prospective randomized control study, but it did show in the findings of this study that if we use hearing aids, it may have a mitigating effect on the trajectory of cognitive decline over time. Okay, so this shows that this is, when we talk about hearing health for our patients, hearing health in and of itself is important, but it's even more important because it's very related to this cognitive this progression of cognitive function. So to round out this section to reviewing the literature, we really need to discuss this study, because this study we hope will be the sort of definitive statement on the relationship between hearing intervention and the development of cognitive decline. Okay, and so this is called the ACHIEVE trial. It's being led by Johns Hopkins, but there are 4 clinical sites. There's one site here in Florida that is participating in this study, and this will be a prospective randomized controlled trial looking at how the intervention of hearing loss influences the development of cognitive decline over time. So we're very excited to see this, and I don't think that any clinicians question whether or not there will be a relationship. The question is, how strong is that influence and what that means for policymakers and that sort of thing. But we're very excited to see the results of that study come out. Okay. So that kind of summarizes some of the literature and the relevant research on this topic. And so now let's move on and talk a little bit about how we as clinicians assess cognitive function, and then discuss this paper pencil versus automated model. So as a clinician, if we want to assess the cognitive function, there are different domains, different parts of cognitive function that we need to evaluate to give a proper picture of what's going on in the cognitive function of that patient. And these are the 6 domains that are described as part of assessing cognitive function. So executive function, which is performing mental tasks; working memory; delayed recall; visual spatial, which is processing shape information; abstraction, so understanding sort of abstract ideas or concepts; and then language or naming. So any instrument that we as a clinician decide to use should incorporate the assessment of these domains of cognitive function. Okay, and so if we think back to medical school, the traditional instrument that we think about is the mini mental state exam. So these are 3 examples of tests that are currently out there available, paper pencil versions of assessing cognitive function. And so the mini mental state exam is a paper pencil instrument, takes about 7 or 8 minutes to perform, requires a trained administrator, so somebody who knows how to administer the test, and it also requires auditory stimulus, which presents a problem for those of us who work with patients with hearing loss. It's a 30-point scale, and it evaluates multiple different domains of cognitive function. It has been shown to have some education bias, so patients with high education tend to do better. And it also is not very sensitive, and so it is really good for documenting significant or more advanced cases of cognitive decline. And so that brings us to something called MoCA, or Montreal Cognitive Assessment. This is very popular in hearing-related research, and this is a similar type of test, paper pencil test. Takes about 10 to 15 minutes to perform, and it has a lot of the similar features of the mini mental state exam. That one of the differences is that this is more sensitive for detecting early stage or mild cognitive impairment. So it's a step forward, because we want to be able to pick up some of those earlier, more mild cases of cognitive impairment, but it's still a paper pencil exam. And then the third is something called the SLUMS, St. Louis University Mental Status Exam. And so this is used a lot in the Department of Defense. And this test is also a paper pencil test, has many of the other features. It is adjusted for education level, so it doesn't have that same education bias, and it's also highly sensitive and specific. So there are some good instruments out there for doing paper pencil evaluation of cognitive function. I'm a busy clinician, and many of the people in this session are busy clinicians. And if I think about implementing a paper pencil exam in my clinic, it's just not feasible because of the time that's required and the expertise in administering the exam. And so that's where we start talking about what if we brought in an automated method of assessing cognitive function? How would that look? And so this slide summarizes some of the benefits of automating this process if we are going to now incorporate that into a busy clinical practice. Okay, and so some of these, we'll kind of review some of these here. First of all, we know that many of these paper pencil tests have bias, right? So education bias, socioeconomic factors that include that, and an automated system can remove some of that bias. Secondly, if you're doing a paper pencil test, then there are distractions, right? So if they can't see the paper, or if your pencil's dull, or your pen stops working, or there can be a significant amount of variability from one test to the other. And automated testing has shown to remove those distractions and standardize the process for patients. Additionally, in automated testing, we know that we can remove the ability to learn and to learn the test from one test to another. Okay. Third is that automated testing accounts for differences in the physical ability of the test taker. So if you think about this, tests of cognitive function should actually test cognitive function. And if a patient has vision loss hearing loss, or poor motor function, that could influence the outcome. And many of these paper pencil tests have that problem. And so automated testing overcomes those barriers by making this so that it adapts. It's called adaptive psychophysics, but it basically adapts to the patient's ability so that we are getting a more pure sense of their cognitive function and not, and not inadvertently testing vision or motor skill. And then finally, an automated test does not, this is important for me as a clinician, it does not depend on a trained administrator of the test. In my clinic, I have to have a way to test that we can have our nurse or MA administer the test and get the same result every time. And so these are some of the benefits and advantages of automated testing. Okay, so now we've talked about hearing loss and cognition, and we've also talked about assessing cognitive function in real life. Now let's spend the rest of the time talking about if you or I as a clinician decide to incorporate cognitive testing into our practice, what does that look like and what are the advantages in that and how does that help patient care? Okay. So I think that the first thing to understand, just to kind of take a step back a little bit, the first thing is to understand a little bit about what's going on in the hearing market, right? So we have technology innovations that are changing the way hearing healthcare is delivered. And we also have capital investment from, corporate capital investment. And the result of that is we're seeing sort of a stratification of the hearing market. And there's a place for each one of these outlets of delivering hearing healthcare, but they are becoming strikingly and more different. So if you think about this over the counter and online direct to consumer, cost is down and service is down. So patients don't expect the same level of high touch service, but they also save money, right? And so we have to think about where you and I as otolaryngologists and audiologists fit into this model. And we should occupy the top of this sort of what we call medical model. And the medical model is characterized by unparalleled diagnostic capabilities. So when patients come to our clinics, we should be able to diagnose better and more accurately and more comprehensively than the other the other outlets. And we should also have treatment options that are unparalleled, And so I think that's how we as otolaryngologists and audiologists continue to build out this medical model so that we can remain competitive in an increasingly stratified market. And so there's an increasing importance for you and I as clinicians to be able to differentiate ourselves and figure out and maintain that status at the sort of the top of this medical model. And that's where I think cognitive testing helps us from a clinical and competitive standpoint. Okay. So when I think about in my practice, the reason why I have incorporated cognitive testing into my practice, it's some of these items listed here. So first of all, it makes me a better doctor, right? So if you ask patients, what are the health problems that you are most concerned about? Cognitive decline in Alzheimer's is repeatedly one of the health problems that our patients care most about. More than cancer, more than heart disease, more than all kinds of other issues, cognitive decline in Alzheimer's, losing our cognitive function is something that our patients just care about in their lives. And being able to have a role in that for our patients, I feel like makes me a better clinician. It also, as we discussed earlier, differentiates my practice compared to other, other practices. There's also revenue opportunities, right? And so when it comes to cognitive assessment, there are basically 3 ways in which a cognitive screening or cognitive testing can bring revenue into our practice. The first is that it allows us, we can bill for the test or charge for the test. So just, charging for revenue from the test itself. Secondly is increased conversion of hearing aid sales, because patients now understand that they are investing in their cognitive health and not only their hearing health, that they go together. And third, we know that when cognitive testing is included in the workup of hearing loss, the average sale price is higher as well. So people are willing to invest in their healthcare. So those are 3 areas that we know that we can generate revenue through this. So the next reason that I have incorporated this into my practice is it increases traffic. So when primary care physicians and other clinicians in the community see that we are incorporating this in our regimen, it increases traffic and retention of our practice. And it places us very securely in a very important role in the overall health ecosystem in our communities. So those are some of the reasons why I have incorporated this in, and I think it makes sense for otolaryngologists to incorporate cognitive screening into their practice. So this slide I just want to discuss very briefly. This slide is a summary. So if you or I are going to incorporate cognitive screening into our practice, there's two obvious times that it makes sense to do the test. One would be to do the test when they see the physician, and the second would be to do the cognitive test when they see the audiologist in a hearing aid evaluation. And so I just want to take a couple of minutes and just discuss briefly some of the implications of each of those and what I've seen in my practice. So option one is what I do in my clinic. I've elected to use option one. And basically that is the nurse puts the patient in the room. The patient is sent for a hearing test if they don't have wax in their ears. They come back after the audiogram, but before they see me, the cognitive screen is performed. Then when I go into the room, I have the audiogram and the cognitive screen available, and I'm able to review those with the patient. And then I make the referral for hearing aid evaluation. The audiologist then uses that information during their evaluation. So some of the implications of doing it this way is, one, I bill for this test. Okay, so we have some data that some payers will actually pay for this test. Not all payers, and it depends on your diagnosis, and there's some details, but I bill for the test. Secondly, incorporating this into my visit makes my visit more complex. And we know that future changes in evaluation and management coding are all going to be based on the complexity of the visit. So incorporating this increases the complexity of the visit. And then secondly, I'm able to actually review the results with the patient, which I think is very important, and stress the importance of this. The second option would be that nothing changes with the doctor workflow. The patient gets the audiogram, we see the patient, we send them for the hearing aid evaluation, and then the audiologist performs the cognitive screen during their hearing aid evaluation. And so some of the implications of this is that one of the advantages is that there is no change in physician workflow. And for some physicians, that's very important. Also, it sort of establishes the audiologist as a leader and playing a key role in this cognitive health, which I think can be important. And then the third thing is that if you are a practice that has service plans in your hearing aids, and you can use the cognitive screen as sort of a bundled option in some of these service plans. And so it can be used as an opportunity to create value for service plans for your patients. So there's different ways of looking at this. In my practice, I've elected to use option one. And then the other question that we have to ask ourselves is, once you do the cognitive screen and the cognitive test and you get the result back, if it doesn't change anything that we do, then it may not be very useful. Okay, and so this isn't the end all be all, but this is an example of a protocol that we developed in our clinic for if the cognitive screen was performed during the hearing aid evaluation. So if the audiologist does the cognitive screen during the hearing aid evaluation, what are the actions that are initiated based off of the results? And so you can look at this, we'll kind of start from right to left. But if you start from the right, basically, obviously, if there's red flags, otalgia, drainage, vertigo, then they need to follow up with the doctor first. Okay, so we'll take that one aside. The purple column that you can see there would be the scenario in which the hearing is normal, but the cognitive function is decreased. And that is going to happen sometimes. They don't have a hearing loss, they don't need amplification, but we have picked up cognitive decline. And this is this places us as the otolaryngologist in an interesting situation in terms of being on the front lines of medicine now. We have actually screened and identified this problem. It can actually really benefit that patient by getting them to their primary care physician. So we send their hearing tests and cognitive screen results to the primary care physician and encourage follow-up. because then this clinician can take action as needed. Okay, and so what's interesting about this, not only does this help the patient, this also becomes a marketing opportunity to let your referring physicians know that you are doing this, and that this can benefit their patients as well as yours. So then the third column here is if there's hearing loss present, but the cognitive function is normal. Okay, so in that situation, obviously we treat the hearing loss, and then we also encourage healthy habits for brain health. And then the final column on the left is what happens when we have a hearing loss and a cognitive decline. So in that situation, what we do in our clinic is we treat the hearing loss, and then 6 months after that intervention, we repeat the cognitive screen. And if it's the same or improved, then we continue observation. If the cognitive function has decreased further, then we involve the primary care physician. Okay, so those are some of the different decision points that we use in our clinic. I think every clinic can do it a little bit differently, but I think this is working well so far in our clinic. And so then our kind of final slide here is just to discuss, I don't think that we have all the answers. I've been doing this for several months in my clinic, and I think my experience has been that patients love it. They love understanding how their cognitive function works. I will say that we have to be careful in how we counsel patients, because this is very powerful information. So I never tell patients that if their cognitive function is low, they're going to develop dementia. What I talk to them is about, I have this discussion with patients about cognitive load and how we can improve their brain health by treating their hearing loss. Okay, and so that we have those discussions with patients. But I don't think we have all the answers. I think we're all excited about the ACHIEVE trial in terms of the long-term implications for developing dementia. But I think that there are some other more proximate questions that I'm very interested in, and that I hope that we as a community can answer. And one of those questions is, does cognitive screening have any predictive implications for amplification or cochlear implantation? In other words, if I have a patient who's considering cochlear implantation and their cognitive screen is very poor, does that give us any predictive ability or prognostic ability in how we expect them to perform with their cochlear implant? I think that's a very interesting study that should be done. Okay, and then the converse of that is also true. If a patient has a hearing intervention, so amplification or cochlear implantation, how does that intervention influence their performance on this cognitive assessment? This is not saying long-term development of dementia, but just if we intervene for 6 months, say, with hearing aids or cochlear implant, at that 6-month post-treatment, what does that do for your ability at that moment of time to perform on these cognitive tasks? And so I think that that's another study that needs to be done. And so I'm really interested and excited about the incorporation of cognitive screening into our practices. I think we as otolaryngologists can play a very important role in this, because we're sort of on the front lines. We see this day in and day out with hearing loss, and I think that it expands the impact of our specialty in the overall health environment. So I think with that, I'll go ahead and stop, and we can open it up for questions and discussion. Thank you.